All right, we'll go ahead and get started. So last time we met, we introduced this arena of skin and soft tissue infections. If you recall from last week, we talked about minor things, folliculitis. We talked about carbuncles and furuncles. We talked about abscess. We got to cellulitis, and pretty much said that for something like folliculitis, you know, local therapy is going to be good, warm compresses, but if it's not resolving, you might need to get some antibiotic cream. We talked about impetigo, and what was the other infection associated with impetigo that we talked about? Ecthyma. Okay, so impetigo is more superficial on the skin, on the face in particular. Ecthyma tends to get a little bit deeper down. So when you have impetigo, topical mupirocin seems to do the trick. Ecthyma being a deeper infection probably requires oral therapy with an anti-staphylococcal penicillin perhaps, or first generation cephalosporin. You treat that from the bottom up. If the impetigo is not localized to one area on the face, there's multiple lesions, then that's probably a good indication for oral therapy as well. When you get into these furuncles and carbuncles, and then more specifically an abscess, the size of the abscess and the overall health of your patient is going to really dictate how you go about treating that patient. Incision and drainage is really the mainstay of therapy for an abscess, regardless of its size. And then the decision to follow up with antibiotics largely depends on the size of the abscess and risk factors associated with the patient. If in today's day and age, if you have an abscess around 2 centimeters in diameter or greater, cut it, break it apart, drain it, irrigate it, and then send that patient home on some oral therapy, and that will do a couple things for that patient. Number one, it'll increase the likelihood of a clinical cure. It will prevent the spread from somebody up to somebody else, and then it will also help prevent recurrences. Okay. And then that took us to cellulitis. And if you recall from last week, what's the most common organism associated with cellulitis? Is cellulitis a purulent or a non-purulent infection? It's non-purulent. Okay, since it's non-purulent, that sort of leans towards what gram-positive organism? Are you thinking 9.9 out of 10 times? Group A strep, all right? Group A strep. So if you see somebody presenting with cellulitis and they don't have any other risk factors and it's a mild cellulitis, oral therapy with the first generation cephalosporin is probably going to be just fine. If you're really confident, actually some people might just use amoxicillin, all right? When you start to superimpose risk factors on that patient and they present with some more concerning signs and symptoms of an infection, systemic involvement, if you will, that's when you really need to start entertaining the thought of admitting that patient, getting them started on some IV therapy initially, and then de-escalate to oral therapy, especially when you get the results back from the lab, if they're able to tell you what the offending organism is. Okay. And then if you have a really nasty case of cellulitis, a really bad case of cellulitis, like we saw with this fella. Remember this guy from last week, when we saw him, he had this spreading erythema covering a large section of his lower limb that may have just started from a bug bite, he thinks. And he did have a positive exposure to the healthcare environment. So that sort of elevates your risk or concern about what might be causing this particular infection. And he had some recent surgical procedure as well. So all of that sort of portends a bad outcome if we don't be aggressive up front. And when I say aggressive, it's a good area here. It's a large area of cellulitis. What is aggressive in your perspective? He's got positive healthcare exposure within the last 3 to 6 months. He probably got some antibiotics secondary to the surgical procedure he had, and now he presents with this. What are you worried about when you see this? We know that cellulitis is most often caused by group A strep, but considering his history, we also have to start thinking about Staph aureus as well. Okay, it's non-purulent. We said that. Does that automatically mean it's not staph? No. Okay. So in your broad spectrum approach here, I think we agreed on Vanco and then Pip/Tazo last week, didn't we? Are you comfortable with that up front? Yeah, because the Vanco is going to afford you coverage against, first and foremost, everybody. MRSA. Does Vanco cover strep? Absolutely. Absolutely. Do you want to use Vanco to kill strep? No, heck no. But it kills strep. Right? Does the Pip/Tazo kill strep? Absolutely. Does Pip/Tazo kill staph? Trick question, right? What flavor of staph succumbs to Pip/Tazo? MSSA. All right, but MRSA won't die from strep, or excuse me, Zosyn, Pip/Tazo. And then gram negatives, if this guy has a risk of gram negatives causing his cellulitis, albeit rare, Zosyn will do a nice job there. And then what if by chance this fella has an anaerobic infection? Okay. What if an anaerobe, unlikely with cellulitis, but nonetheless, maybe there's something brewing deep down that we don't know about that's manifesting as this spreading erythema. Does Zosyn cover the anaerobes? Absolutely. Okay. Now, we have pretty much just launched a cannon at this guy's leg. And we want to do that because we don't want to get behind the 8 ball. We want to stay in front of things. So we got him on Vanco and Pip/Tazo. And then not too long after that, group A strep is identified as the causative organism here. What did we say last week is order number 1? The attending says, Eden, go modify this guy's therapy. All right. I want you to put him on an appropriate therapy for group A strep. Right, and just let me know. Amoxicillin. Okay. So Amoxil, PO. Maybe when we send him home. Okay. What do you want to do about the existing orders? DC Vanco, DC Zosyn. We know it's group A strep. We knew group A strep is literally allergic to penicillin. Okay. It hates penicillin, so we're going to put them on penicillin. Penicillin G, 4 or 5 million units, IV, Q4 hours. And folks, that's going to do wonders for this guy's cellulitis. Okay. Get him under control. He's already going to be improving after the Vanco and the Zosyn. Could you leave him on Vanco and Zosyn? Would that cure the infection? Yeah, I think so. So would an autoclave, but we're not going to do that. So let's get rid of this unnecessary broad spectrum antibiotic regimen. Yeah, there's a cost associated with everything. Leaving him on the Vanco will do more harm than good. That combined with Zosyn, I mean, that combination right there has already been shown to impact kidney function. So that's not the best combination anyhow, especially if somebody you think has some compromised renal function. Okay. Get this guy going on some Pen-G. Let that area of erythema, that cellulitis, start to resolve. See improvement in his symptoms. Defervesces, he's afebrile, respiratory rates intact, hemodynamically intact, heart rate's intact. he's improving, guess what? We can discharge him, and we can discharge him on something like amoxicillin to finish things up. Okay. All right. What questions do you have about cellulitis? I like to think in the real world, it's cut and dry like this, but I almost think like everybody gets treated as if they have a horrible looking area of erythema on their leg. Everybody that comes in probably is going to get aggressive therapy up front, and then de-escalating once you know what's going on. All right, let's move forward. Have you heard of flesh-eating bacteria? Are you familiar with this? You've probably seen something like this in the news years and years ago, but flesh-eating infections largely refer to something called necrotizing fasciitis. Right? So we've got this 15-year-old kid, he's out horsing around with his friends, and he's presenting with severe left arm pain, erythema, and edema. Right? We see this bullous blisters covering his arm, which began to appear yesterday, and they've gotten much worse. Like I said, the pain, the swelling, and the redness have worsened since yesterday. The pain and the swelling in the arm worsening. He went hiking with his friends, fell on a rock, cut his arm. Right? What's the most appropriate therapy for someone like this, presenting with these symptoms at this time? You just give him some intramuscular ceftriaxone and admit him to the medical ICU. Do you call for a surgical evaluation and initiate imipenem-cilastatin plus Vanco? Give him some Piptazo and Vanco and go to the general medical unit, or call for a surgical evaluation and start Pen-G plus clindamycin. So we'll think about those options for a minute as we move forward. Necrotizing fasciitis is, in fact, a medical emergency. This is probably one of the worst infections that you'll ever encounter if you have the luxury of participating in infectious disease rounds. Right? Medical emergency. This is a very, very aggressive and rapidly spreading infection. Okay, and it gets deep down right up to the superficial fascia. So everything from the top down to the fascia is involved in this infectious process. If it goes below the fascia and gets into the muscle, that's called myonecrosis, which is a harbinger for poor outcomes as well. This is fraught with tissue destruction. And if it's not addressed correctly, if it's not treated correctly, it carries with it a pretty high mortality rate. People who present with necrotizing fasciitis often have a recent traumatic event or a recent surgical procedure. However, what we can see is that you don't need to have surgery or trauma to present with necrotizing fasciitis. Something very, very innocuous, something very, very simple actually can create an entry portal for a bad bug to get in and then start manifesting all of these signs and symptoms associated with this disease or infection. The preponderance of necrotizing fasciitis involve the legs. Okay. So risk factors, again, too, necrotizing fasciitis doesn't necessarily discriminate. If you're in the wrong place at the right time and you cut yourself on the wrong implement, you can end up with necrotizing fasciitis. The organisms that cause this are out there in the environment. Okay. So trauma, though, trauma to the skin, cutting it open and giving access to these bugs, minor insults, as we suggested, even a muscle strain. Right? Even a muscle strain can lead to necrotizing fasciitis. And it can happen in anyone. Now, not surprisingly, diabetics are at increased risk. Diabetic patients have compromised immune system. They have poor blood flow. So they are at increased risk for just about everything, right? Vascular disease, especially to the extremities, when you have poor circulation to the lower limbs, fluid tends to accumulate. You have poor blood flow down there, meaning your immune system in the lower extremities is not as robust as it would otherwise be in certain other parts of the body. Again, edema, and then injection drug users seem to have an increased risk of necrotizing disease as well. And then when you categorize necrotizing fasciitis, kind of gets lumped into three different types: type 1, type 2, type 3. So type 2 infections, despite the name, end up being monomicrobial. right? Type 2 infections typically result from being infected by one bug, okay? And a lot of times it's a very virulent form of streptococci. Type 1 infections are often polymicrobial. Right? So you might see gram positives and gram negatives leading to the infection. And then lastly, we have this type 3, which is a sort of like a myonecrosis then, clostridial myonecrosis. Clostridium is an anaerobe, and when it finds its way into the lower recesses of the skin down into the muscle, it can really start to wreak havoc on the tissue, evolve a bunch of toxins, and start to just degrade tissue like, you know, butter melting out on a summer day, if you will. So Clostridial myonecrosis type 3. And the systemic signs and symptoms, again, too, are consistent with a lot of the other infections that we've talked about: fever, malaise. You know, if it's really bad, your patient's going to present with hemodynamic instability, respiratory rate could be up, and then a constellation of labs might be abnormal as well, depending on your patient. The area itself, inflamed, discolored, and heck, it could be gangrenous as well. And you see that particularly with the type 3 infection. And then interestingly, that you have the subcutaneous tissue. They describe it as sort of a wood-hardened induration, right? A wood-hardened induration, opposite to what you see in cellulitis or an abscess. So remember, with an abscess, you have this area of fluctuation. It's fluctuant, so you press down on it and it pops back up, okay? Cellulitis is a little bit more tender, okay? But when you have necrotizing fasciitis, you actually might have the area pushing out a little bit and it's hard, it's stiff, right? So it doesn't give, it's not pliable like you would see with the aforementioned infections. And then what causes necrotizing fasciitis? I mean, in theory, any virulent organism could probably do it, but when you look at the statistics, toxin-producing forms of strep pyogenes are most common. These particular strains of strep are evolving a variety of enzymes and toxins that, when they start to replicate in the infection nidus, it just starts to dissolve and degrade all the surrounding tissue. Community-acquired MRSA has also been implicated and shown to cause necrotizing disease. And there are cases of MRSA co-infecting with strep, group A strep. So if you're looking at individuals that are presenting from the community, those are probably the most common organisms. However, the history does become pretty important, though, when considering what might be causing the necrotizing disease. You ever see those individuals who just like to cliff dive, you know, off a 50, 100-foot cliff into the salt water? Looks fun, doesn't it? As long as there's not a rock down there. So you cut yourself in the ocean, you get bacteria into that wound. There's a strain of Vibrio called Vibrio vulnificus. Yeah, that's a pretty nasty gram-negative organism to have get in your body. It can start to replicate and then start to dissolve tissue as well. Aeromonas. All right, so if you don't want to cliff dive into the ocean, you want to cliff dive into the quarry. That's fun too. Been there, done that. That was a long time ago. Not very smart, but nonetheless, it's a freshwater cause. Right? So you cut yourself in the quarry, Aeromonas can get into the wound. And Aeromonas, again, producing toxins, can do the same thing. And again, we said type 1 is mixed, and then type 3 is essentially an anaerobic infection. So the type 1 infection, I think a lot of it has to do with, again, what the exposure is and what the risk factors are with your patient. I would expect a type 1 infection, polymicrobial, to be more common in a diabetic patient as compared to young, healthy individuals like yourselves. And then the gas gangrenous myonecrosis that is type 3 infection, again, wrong place at the wrong time with regard to Clostridium. So how do you diagnose this? Early on, early in the presentation, it can be kind of difficult to discriminate between a necrotizing process versus a general cellulitis. And so you may not be as inclined to be as aggressive with initial presentation. It's hard to tell them apart sometimes. The deep tissue involvement that individuals with necrotizing fasciitis present with can kind of clue you into the fact that it's a little bit more severe compared to your run-of-the-mill cellulitis. I think one of the giveaways or symptoms that you can hone in on is just the pain. The pain associated with necrotizing fasciitis is completely out of what you would expect. You've got a patient coming in with an area of redness on their arm or on their leg, and they are complaining like 8 out of 10, 9 out of 10 on the pain scale. And it just sounds like it's completely ridiculous. But in fact, that's the level of pain that they're experiencing. And if you lined up somebody else who had a cellulitis in the same area that looked the same, they are certainly not going to complain about that level of pain. So when they're complaining about how painful it is, that's a good clue that it might be something more severe than just a cellulitis. Unfortunately, being unable to discriminate just by looking at the lesion or the wound, you may treat it initially as a cellulitis. And if the cellulitic lesion, the area of erythema, doesn't start to resolve with initial antibiotic therapy and the pain doesn't start to go away with initial antibiotic therapy, that tells you that it's probably more severe. That stiff subcutaneous tissue that would harden in duration, that's a different presentation. They're going to be sick, right? These patients coming in are going to be sick. There's something called crepitus, which is a popping or crackling sound that they might present with as well. That's often an indication there might be something deep down, forming even a gas pocket. And then skin necrosis or ecchymosis. You start to really see color changes. And then certain imaging techniques are probably of value, but there's just not a lot of well-controlled studies out there to evaluate the utility of a CT scan or an MRI scan in diagnosing necrotizing fasciitis and discriminating that from cellulitis. So it probably has some value, but there's not a lot of strong evidence right now to suggest that's the way you should go. Really what needs to be done is a surgical inspection. Okay, so you have a patient that comes in like we described for our 15-year-old with all of this pain and this area on his arm that looks really, really bad. Best thing to do is have a high suspicion then for necrotizing fasciitis. Get your surgery consult now, get some blood cultures, and then let that surgical team take him and basically fillet the arm and see what's going on underneath. And you'll have a better idea of what's going on. When they go in and open up the area of infection, if it's necrotizing fasciitis, there's going to be swollen, dead tissue is really what it boils down to. And it's typically not a purulent infection either. You can try and get a deep tissue biopsy. I'm not sure what the yield is going to be on such a biopsy, but if you get a little bit of deep tissue, you can send that off for culture, see what grows. A needle aspiration could be done as well. So just sticking a heavy gauge needle in there, pulling back, getting what you can get out of it, send that off. And then again, to blood cultures, just get a sample, get a sample, get a sample. The quicker you identify what's causing the infection, the better you can narrow down your antibiotic regimen. Okay? So to treat these types of individuals, immediate surgical debridement is paramount. All right, it's urgent. You got to get in there, open up the wound, and remove all of that dead and infected tissue. And if you do that well, you have a really high likelihood of preventing the spread of the infection and hopefully not only preserving a limb, but saving the patient. So you go ahead and debride the infected area. You come back again in 24 hours and have another look, maybe even sooner, depending on how things are going. And not surprisingly, after you get your blood cultures and your biopsy specimens or your needle aspirate, you start the patient on antibiotics right away as well. Okay. Broad spectrum. We don't know what it is at this point in time. That 15-year-old that was out playing with his friends, cut his arm. Now looks like his arm's going to fall off. So it's not good. So here's how that arm might appear. Bullous lesions that have ruptured. You have ecchymosis. All right. It looks bad, doesn't it? Okay, it looks bad. And then when you cut it open, you fillet the arm, you see there's a lot of dead tissue. Okay, so the surgical team needs to go in there and clean all of that out, right? And irrigate it and clean it out again. And then hopefully what you end up with is what you see here. This is post-debridement. You've got a lot of nice pink, healthy looking tissue there. And hopefully you removed all the infected material. And then a good debridement coupled with antibiotics ought to take care of things. It's going to be a protracted healing time for something like this, but nonetheless, still going to have an arm. Okay. So I just want to reiterate a term. When you go in there and clean all of that infected material out, you're controlling the source of the infection. So source control ends up being very, very important for almost every infection. And then there, control the source, and then the antibiotics will help clean things up. Okay, so empiric treatment. Empiric treatment. Does vancomycin cover gram-positives? Yes or no? Yes. Does Dapto cover gram-positives? Yes. Does linezolid? Yes. Iptazo? Yes. Does a carbapenem cover gram-positives? Absolutely. Does Rocephin cover gram-positives? Globally speaking? Yes. Does metronidazole? No. Okay. Fluoroquinolones and metronidazole. I guess type of fluoroquinolone becomes important. Okay, but by and large, fluoroquinolones do carry with them some gram-positive coverage. So we'll put yes there. Vanco covers MRSA. Dapto covers MRSA, as does linezolid, right? Zosyn, what did we say earlier? No, 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 no. These first three have any gram-negative coverage? Iptazo, gram-negatives, like it, love it. Carbapenems, gram-negatives, like it. Rocephin, gram-negatives. Metronidazole, again, too. We're just going to put metronidazole over there. Fluoroquinolones, gram-negatives. Vancomycin cover anaerobes. Does vancomycin kill anaerobic organisms? I got a vote for no. Anybody think opposite to that? What do we use oral vanco for? Anybody know? C. diff. C. diff and anaerobe? It is. Okay. But do we expect vancomycin to be useful for treating the anaerobes that might be causing necrotizing fasciitis? No, so it's kind of a trick question. We're not going to use vancomycin in the context of this scenario to kill anaerobes. So we're going to put no there, okay? Likewise, we're going to put no for the other two. Piptazo have anaerobic activity? Sure does, as do the carbapenems. Metronidazole, drug of choice. So the combination ends up being important here. And in fact, why do we add on metronidazole to ceftriaxone for a portion of empiric therapy for necrotizing fasciitis to cover the anaerobes? Okay. Are there other drugs that you could consider? Sure. But this is what's really in our toolbox that we're walking around with day to day, patient to patient. And so from an empiric therapy perspective, as discussed, Vanco or Dapto, if for some reason your patient can't tolerate one of the first two, you could use linezolid. I think there's actually a push to start using linezolid more often for necrotizing disease, because not only is it bactericidal against strep, it also interferes with a lot of this toxin production that's occurring in the infection as well. So I don't think it's gained much traction in some of the local hospitals. I asked Dr. Lewis about it about a week or two ago, and they still use Vanco or Dapto, probably Vanco. So you got your MRSA coverage plus your gram-positive and gram-negative and anaerobic coverage. Okay, but when you start to realize where things are headed and what's causing the infection, now you can de-escalate to definitive therapy. So if our 15-year-old was identified as having, a type 2 infection that was being caused by group A strep, a toxin producing strain of group A strep, penicillin, IV penicillin plus clindamycin is your definitive therapy here. Okay. Now I know that you guys are familiar with the use of penicillin in group A strep, and we've been preaching that all semester. What's the role of clindamycin here in the treatment of type 2 necrotizing fasciitis secondary to group A strep? What's clindamycin's mechanism of action? So being a protein synthesis inhibitor, okay, these particular strains of strep and other organisms that cause necrotizing fasciitis are making a lot of toxins. So not only do we want to kill the existing burden of bacteria, we also want to shut down any protein production that these bacteria are engaging in. So the combination there is really to kill the bacteria and suppress toxin production. Okay. And you'll see that, again, Vibrio vulnificus, your seawater friend, ceftriaxone has good activity against this organism, and you can add on some doxycycline as well. Likewise, Aeromonas, doxycycline and Rocephin, or doxycycline and ciprofloxacin. The combination of the quinolone or the third generation cephalosporin plus the tetracycline is regarded as the definitive therapy for an Aeromonas infection. And then Clostridium. Luckily, Clostridium still is sensitive to garden variety penicillin. So if we know that we have that type of organism causing the infection, penicillin plus clindamycin, again, for the same purposes that we described for group A strep. Okay. All right. I don't know how often you'll see necrotizing fasciitis, hopefully not all that often, but when you do, you need to just always keep that in the back of your mind. When you guys go out on your rotations, depending on what type of rotation and where you're at, it's going to be different from region to region, hospital to hospital. So sometimes you got to have a low threshold for really pulling the trigger on certain patients with regard to the antibiotic therapy. Sometimes it's better to be aggressive up front, okay, because you can back off after the fact. But it's hard to catch up when you have given 24, 48 hours of inadequate or inappropriate antibiotics, especially in a rapidly progressing infection. Okay. What's the expectation for an assessment into? You'll get a case just like you saw on the slides. Here's a person, they did this, they're presenting with this. What do you want to do up front? Then it comes back, this is what we're growing. Now what do you want to do? Okay. And common things are common. This is not common. If we see her walking down the streets, we're in trouble. I'm looking for Michonne personally because she's got a samurai sword. Nobody, no Walking Dead fans. Man, am I like out of it? Am I like, is this all nebulous to you guys? What do you guys watch? What do you guys do? What is it? Oh, come on. Yeah, I know you study, but not always. You watch TV, movies, nothing, TikToks, video games. What's that? Brain rot. Doom scrolling. Awesome. Okay, well, I don't know what the cure for that is, but we'll talk about bite wounds. So, bite wounds. Have you ever seen a bite wound? Have you ever been bitten? Yeah. Did you bite back? No. Oh, well, they won. I'm just kidding. Was it bad? Dog? Big dog? Like this?
No, small.
Did it tear open things?
Just actually on my hand, so I just poured out on it.
Vodka?
Yeah, vodka.
Sorry. So you managed it yourself?
Yeah,
Mostly? Okay. Interesting. You did go get some care because,
yeah.
Okay, good. Good. All right. Anybody else want to share a horror story about an altercation you had with a small animal? No? Okay, good. We had this beautiful golden retriever. Dog's name was Mocha. And anybody have retrievers? Okay, so retrievers are very protective of their family and friends. And we had a pool in our backyard. Had some friends come over, and the kids are young. They're jumping in the pool, and the dog is like having a fit. It's like, oh my gosh, they're screaming and yelling and jumping in the pool. And well, Mocha didn't want the kids to jump in the pool. So Mocha would run after them and try and pull them out or stop them from jumping in because the poor dog actually thought that they were harming themselves. And the one girl went down the slide and, Mocha went up and tried to stop her from going in. And well, he didn't stop her from going in, but he did cut open her thigh pretty well. And I was like, oh my God. And there's broke the skin. You could actually see the little bit of the subcutaneous fat come through. And it's like, well, this isn't going to end well. So having said that, dogs are actually the number one cause of bite wounds. Cats are a distant second. And people cause bite wounds number 3. But it's kind of interesting the mechanism behind that. Who's the victim most often? 4th-year pharmacy students, it sounds like. That's a joke. Rabbits, guinea pigs, hamsters, rats, mice, minks, snails, I don't know. Rabbits are interesting. Anybody ever have a pet rabbit? Yeah. What do their teeth look like? Yeah, they're big and they're kind of flat and they come down like this. I mean, so lagomorphs. This neighbor of ours had a rabbit bit my daughter. It was a little birdie bite as far as I'm concerned. This damn thing would not stop bleeding. I mean, it would not stop bleeding. So I had to take her to the ER. It's like, this is going to cost money. Anyhow, this is my dog, Yogi, for what it's worth. A little bit of my family here. We've had this little guy for several years now. He looks pretty terrorizing. But at 6 o'clock in the morning when he's yapping because he's hungry and wants to go outside, you just want to, what you want to do to him. But nonetheless, this looks like a human bite, if you ask me. Okay, somebody dug in really, really good there. That's obviously going to leave a mark. This, it's like somebody stuck their hand there and let the cat bite once, but wasn't sure, so they let it bite him again. I mean, what are you thinking? Okay. And then what do you think this is from? Yeah, somebody was talking some smack and somebody got hit. And then, so that's really the most common mechanism behind a bite wound, as it's described, is somebody punching somebody and having an open laceration on the hand. We used to get a lot of people come into the ER because of an opened hand laceration, i.e., somebody got in a fight. So this is pretty common, actually. If you start to see a lot more of this, I don't know what's going on. And cats are, what do cat teeth look like? I mean, cat teeth are literally hypodermic needles. So, they bite you and then they sink down, and then the bacteria in their mouth and on their teeth is just being deposited down in there. So, but they're adorable, aren't they? No, in my humble opinion. All right, so how do bite wounds present? Okay, you need to keep in mind here when we talk about bite wounds, a wound itself is nothing more than a wound, okay? Not all wounds are infected. That's an important concept. You can have wounds that are not infected, but an infected bite wound could be fraught with swelling, erythema. Patient could be febrile, secondary to bacteria from the wound. If it's been festering for a bit, you could have some leukocytosis associated with that bite wound. And then you could even see lymphadenopathy in and around the area where the wound occurred, where the bite occurred. Okay. And it might take a little bit of time because not only does that bacteria from the oral cavity of whatever the animal or person was that bit the victim need to fester and establish a foothold in the wound, now it has to spread to elicit some of those symptoms. They could be purulent or non-purulent. And they are often polymicrobial. Bite wounds are often polymicrobial. Okay. When you look at the oral flora for dogs, you look at the oral flora for cats and then humans, Pasteurella. All right, so you have this facultative anaerobe that is highly present in the oral cavity of both cats and dogs. You got strep, staph, Neisseria. You got some very interesting organisms that somehow make their way into the oral cavity of cats and dogs. Eikenella, Kingella, there's a couple different types of organisms that are in the human oral cavity, but staph and strep and even Corynebacterium are also isolated from the oral cavity. And then there's a variety of other types of anaerobes that are found in the mouth as well. So you think about everything that is in the mouth of a dog or a cat or a human. You think about a bite and then exposing the tissue to any and all of those organisms. You really don't know what's going to be causing an infection if the wound, in fact, does get infected. So you kind of have to think about that when you're deciding on what to use, if you have to give something for prophylaxis or even for treatment. How do you manage a bite wound? Again, thorough irrigation. You really got to wash it out, clean it out. Did it burn when you put the alcohol on there? Do you recall? Or was it? Yeah, but you knew it was there though. Yeah. So again, too, sterilizing that area is probably one of the best things you could have done up front, because that's going to kill off anything that's still sort of locally in the wound itself. But if it gets deeper down, that's where it gets a little bit more difficult. Thorough irrigation, and that's typically all that they're going to do, unless you present to the provider with a wound infection already, or if you have any of these particular situations. Anybody that's immunocompromised, probably after a bite wound, is going to get some prophylactic antibiotics. Individuals that are lacking a spleen, either they had a splenectomy, we have something called functional asplenia, where the spleen is present, but you have poor circulation to the spleen such that it's not going to function properly. Sickle cell patients have functional asplenia. Those individuals are going to get prophylactic antibiotics. Encapsulated bacteria are cleared from the circulation by the spleen. If the spleen's not functioning, not going to clear them. Capnocytophaga, that's an important organism in dog mouths as well. There's a couple of interesting case reports of owners allowing their animals, dogs in particular, to lick like cuts and wounds on their body, and these individuals end up presenting to the ER with sepsis secondary to capnocytophaga. Liver disease, again, too, the inability to synthesize complement, antibiotics prophylactically. If the area is edematous, antibiotics. If you have severe injuries to your hands or your face, right? These are very delicate areas of your body. So we want to make sure that we don't have to come back in and debride any area of the face or the hands. We don't want to have to do a surgical procedure to clean things up if we don't have to. If you get bit close to a joint, a major joint, what can happen is you could have contiguous spread of the bacteria from the bite wound into the joint, and that could lead to something called a septic arthritis. That can be difficult to treat as well. So if it's by a joint, we're going to go ahead and give some prophylactic antibiotics. And of course, deep injuries, if a tiger bit you with a 6-inch canine, that's going to probably require some antibiotics. Thank you. I will not be back on Wednesday to teach. Dr. Lewis will. Should we close the wound? Pretty much only on the face. All right. After you clean things up, after you clean the wound up on the face, then you can go ahead and close the wound. Otherwise, you kind of just let it heal on its own. All right. And then what do you use prophylactically or even for treatment purposes? One of the most common antibiotics that is used to treat bite wound or used in prophylaxis for bite wound is augmentin. All right. We don't want to have to admit anybody for a bite wound. You shouldn't have to admit for a bite wound. But if you have a situation where you need to give somebody something after you clean it out, augmentin. All right. Augmentin is good because it covers gram-positive organisms. It will cover gram-negative organisms. And the addition of the clavulanic acid affords it with anaerobic coverage as well. The only thing that augmentin is really lacking is MRSA coverage, okay, and pseudomonal coverage as well, but unlikely to have pseudomonas growing in your mouth, okay? And you really only need to do it for a couple days. If you encounter a patient who got bit several days ago, and you can just tell by looking at it and looking at the patient that it's infected, that changes things a little bit. And that's where you need to start using IV antibiotics. If they have systemic signs and symptoms of an infection, you're going to have to up your game a little bit, okay? There is a posting on Canvas, table 5. I don't know if anybody's looked at it, but in that table, that PDF that's posted, it kind of goes through the IDSA recommendations for parenteral therapy for bite wounds. So again, to upfront MRSA coverage, probably with aerobic and anaerobic organism coverage, similar to what we described previously. What will I want you to know? This is what you're going to get asked probably the majority of the time. What's the drug of choice for bite wound prophylaxis? Augmentin, okay? Don't reflexively just say augmentin because that's the correct answer, but understand for yourself why augmentin, what augmentin affords you in terms of coverage, and where the liability is with augmentin, okay? All right. That's all I have with regard to bite wounds and necrotizing fasciitis. What questions do you have? None? None, yeah? Okay. You want to talk about some diabetic foot infections? Not really. Me either. But what you come to realize is that diabetic foot infections continue to be on the rise. And you come to realize also that they are very, very poorly managed. Just in time, right? Okay, we'll go ahead and take our break. Is that cool? You guys want to take a quick break then? And we'll come back in about 5 to 7 minutes and pick it back up.
Oh, question.
Yes, ma'am.
Regarding bites, are we going to talk about rabies, or is that maybe more you know?
Oh, geez, that's a good question. Never really talked about rabies or thought about rabies. We took propaganda.
I did.
So, I mean, we had it as a whole topic.
I didn't know, just since it's so involved in a lot of
It's pretty, well, again, now you're opening up the whole bite realm to many, many things. You don't even need to get bit to get rabies, as you know. You inhale their own saliva from their own animal. Yeah, rabies, I never really considered because you don't take it the moment when you have vaccines as therapeutic vaccines. Yeah. But I don't think they ever talk about any vaccines.
they are a very small subset.
Your rabies vaccine. I don't
That was
think
a
that's
long time
something.
ago.
I don't think that's something that you guys give at the pharmacy.
No, like at the hospital we do all the time.
Yeah, that's one. I was when that kid got hit, but and the problem too is that
Why?
ideally, when an animal bites, like a child or even an adult, they'll ask you, well, you remember, you have my animals, did you get it? No. They don't want to cut it open and see, do we need to give you this or not?
We just recently had like not that. It's a fox bite.
Fox bite. Really? What do you like?
Well, I would have only green. I guess it was some neighbor's pet fox. And
Sure.
it was attacking your dog and they broke it up.
That's unfortunate. Yeah, it's funny. You don't see foxes a lot, but they're out there. They come out at the right time. We had some foxes. Not so much that much anymore because they developed a lot of but going back to your original question, it's something that I mentioned. At the end of the day, what are you going to do? They're going to have 2 years to answer for it. You're going to send it. And then once it reaches the pharmacy and it's in the nurse or the doctor's hands, it's up to them. And then come the time you have to come back, you're relying on that patient or returning for the subsequent injections. And that's where things go haywire. But you like to think that a social
Yeah, we deal over the summer when it's tractor pull season. All the bad exposures. It's terrible trying. Yeah, and it's terrible trying to get those people who come from out of town to then get the subsequent.
That costs a lot. Yeah, and last thing you want is no problem. Bo, how are you? You go take it. Is that your gavel up there?
That is my gavel.
I just was noticing that. Don't let anybody see. So.
She's still doing. I was using it. Oh, wait. They lost. Watch this question. Yeah.
All right. Let's go ahead and talk about this other complication of diabetes and diabetic foot infections. As I suggested, these are going to become more and more common as the population ages, as our population continues to develop diabetes. Along with that are the benefits of diabetes, one being increased risk of infection, especially on the foot. So diabetic foot infections, again, to need to discriminate a foot infection versus a foot wound, okay? A diabetic foot infection can be superficial or deep, and it is an infection, and it's associated either with the subcutaneous superficial tissue, but it can get pretty deep. It can butt up against the bone, and it actually can cause an osteomyelitis or bone infection in the foot. If you want to save the toe, if you want to save the foot, if you want to save the lower limb, you need to really implement proper care techniques, proper management. Because if it's mismanaged, prolonged hospitalization, the cost associated with diabetic foot infections is just astronomical. I mean, it is up there. Hospitalization, osteomyelitis, and then down the road, if it continues to be poorly managed or doesn't resolve, amputation can result. So what causes a diabetic foot infection? Not surprisingly, uncontrolled diabetes. All right. What does uncontrolled diabetes result in with regard to the normal physiology of an individual? So you get nephropathy, you get neuropathy, and you get a variety of other vascular abnormalities. So all of this sort of creates the perfect storm, whereby an individual who has uncontrolled diabetes has poor circulation to the lower extremities, has neuropathy secondary to their uncontrolled diabetes. It could be motor neuropathy and autonomic neuropathy. And all of that then leads to some type of self-induced trauma, if you will. The vascular insufficiency that is noted in diabetic patients, again, too, is you have poor blood flow, you have poor circulation to the lower extremities, you have poor oxygenation, your immune system doesn't get down to where that infection is. It can't protect and it can't clean things up. So that contributes to an increased risk of infection in your diabetics as well. All of that leads to wound. So diabetes. Diabetes can cause a motor neuropathy. It can cause a sensory neuropathy and then an autonomic neuropathy. A motor neuropathy. All right, you and I, we walk toes pointed out, heel toe, heel toe, heel toe, heel toe. The diabetic patient's going to walk a little bit differently. Right? And they're going to start to create a little bit of drag or friction on their foot. And what do you think that drag or that friction that's abnormally occurring in that shoe is going to do over time? It's going to start wearing on a particular area of the foot over and over and over. Okay? That's the first problem. What's the middle point? So you've got motor, you have sensory. Heck, I can't even feel that I'm doing that. Feels fine to me. What's your problem? Right? So you do it over and over and over. Okay. So now you're walking abnormally, and you're creating this friction that you can't even sense yourself. And then the autonomic component. Okay. So like it or not, your feet sweat. All right. And that sweat isn't to gross out your partner. That sweat is intended to help try and create a little bit of moisture on the foot. Because what happens when your skin dries out? It cracks, okay? Especially in this beautiful Northwest Ohio weather. I mean, what could go wrong? So you have that autonomic neuropathy kicking in. You have decreased sweating and moisturization of the feet. Now put all of that together. And what do you end up with? An area that you're constantly rubbing. You don't even know you're rubbing. That's dried out, has a propensity to crack and open up, and now you've got a callus which gets injured, and then you keep doing it and doing it, and now you have a lesion. Okay, and unless you look, you might not even know it's there. So what does that wound look like? How bad is that wound? Okay. Well, a wound can be erythematous. It can be red, not because it's necessarily infected. You could have a local immune response occurring at the wound as part of the normal healing process. Right? So redness by itself doesn't necessarily suggest an infectious process, but it's pretty consistent with one. Warm to the touch, the swelling, and then the pain. Okay, rubor-dolour-Kaler tumor. We mentioned this last week. Right? Whenever you have that going on, then you kind of start to realize, yeah, this is probably infected. And then when you look at it, discoloration, you know, is there an exudate? Is it purulent? All of this is then going to help corroborate a diagnosis of not just a wound, but an infected wound. And then a foul odor. Okay. Yeah, feet don't smell great to begin with, but when this wound is emitting a foul odor that smells the equivalent of raw dead meat, then you know that you have a problem. Okay. All right. And what causes a diabetic foot infection? Well, diabetes is, of course, the risk factor here, so you can right away surmise it's going to be pretty bad. But what the literature will suggest is that the depth of the infection sort of predicts the organisms involved. If you have a relatively superficial wound that gets infected, it's most likely going to be staph or strep. Right? So the higher up it is, the lack of involvement subcutaneous and deep down, right? Staph and strep. As you start to progress downwards in the depth of the wound that's infected, staph and strep, absolutely. But then you start to add on other organisms, gram-negative organisms in particular. So it becomes polymicrobial often. And then when you start to see this dead tissue effect, this necrotic tissue that's emitting this odor, that's when you start to suspect anaerobes are involved. Okay. Staph and strep, most commonly isolated, without a doubt. Gram negatives, the deeper down you go. And then when you have this ischemic wound that lacks oxygen and oxygenation, and it's pretty bad looking, anaerobes. And then to diagnose a diabetic foot infection, this is continually evolving. And they came out with some new guidelines recently, but typically 2 or more of the classical signs of infection. Again, if you culture something and they look like they're sick, yeah, you have an infection. Just clinically looking at it, and you see pus coming out, and they have a fever and leukocytosis. It's a wound. It's infected. Culture the wound before you start antibiotics. I can't tell you how important that is. If you give antibiotics and then take a blood culture, you're going to sterilize the blood. So your recovery is going to be pretty bad. Okay. The wound itself, if you give antibiotics and then culture the wound, chances are you probably are going to be okay in that regard. Blood supply isn't that great to the wound anyhow. New diabetic foot infection should get an x-ray. You want to look to see, is the underlying bone intact, right? Or is there a process going on to suggest osteomyelitis? If it's really, really bad, it's been festering for a while, a patient needs to be admitted because they're going to have to debride the area surgically, clean things up, and give parenteral antibiotics. So there's a couple different scales that are used. The PEDIS grade, and then Infectious Disease Society of America. I mean, they all have their little classification systems to try and determine how bad the infection is, but you can read through these. Into no classical signs or symptoms of infection, no purulent discharge. I mean, really, that's just a wound, okay? That's a wound, no infection. Don't need any antibiotic treatment, just do general wound care. Keep it clean, irrigate it, no antibiotics needed. If you have skin, subcutaneous tissue with a relatively small red area surrounding the wound, and you can rule out other causes of inflammation, that's going to be equivalent to a mild infection. Right? So superficial, subcutaneous, small lesion, mild infection. You can manage the mild infection orally with an antibiotic that will cover the usual suspects. If the wound area of erythema gets larger than 2 centimeters and it starts to get a little bit deeper, but yet still don't have any bona fide Sears criteria, we're going to call that a moderate infection. And depending on the patient themselves, IV or PO, start on IV and then de-escalate to PO, keep them there for a day or so, and then send them on their way. But if it's really bad, 2 or more of the following Sears, large lesion, we'll call that a severe infection. That's going to get you a ticket to the hospital and some IV therapy. So again, I'll reiterate this. No infection, no antibiotics. Infection, antibiotics, okay? Mild infection, gram positives typically, okay? Gram positives, staph and strep. Give an appropriate drug to cover staph and strep. Cover MRSA. Honestly, always. I mean, it just seems like MRSA it's so prevalent now. Probably better off just covering for it up front in someone like this. Diabetic patient has some inflammation, immunocompromised. Probably not a bad idea just to start on something with MRSA coverage orally. Severe infections, again, too, very much like we described for necrotizing fasciitis, broad spectrum, MRSA coverage, gram positive coverage, gram negative coverage, anaerobes. Okay, those deep infections are polymicrobial and they may involve anaerobic organisms. Pseudomonas is a little a little interesting. I don't think that everybody covers Pseudomonas initially. There are some specific indications, though, to cover Pseudomonas, in particular, recent hospitalization, recent antibiotics, healthcare exposure. Does the patient have a history of a Pseudomonal infection? If yes, 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 or yes, cover Pseudomonas. What's the prevalence of Pseudomonas in your area where you're practicing? Is it high? Do you have a warmer climate that you live in? I wish, but it's a consideration. Do you have that individual, that diabetic patient that likes to dip their toes in the water, and dangle them over the dock? Again, if there's frequent water exposure, Pseudomonas loves the water, so that's a pretty good idea. Cover Pseudomonas if you have somebody doing that. If it looks really, really bad, probably a good idea to cover Pseudomonas. And let's be honest, most of the regimens that you're going to recommend anyhow to cover the gram negatives and anaerobes is probably going to overlap with Pseudomonal coverage. If you look at some of the guidelines, when you're looking at diabetic foot infection, that's mild in nature, any of these would be just fine for methicillin susceptible Staph aureus. And when you start to suspect or worry about MRSA, Bactrim or doxycycline is really what you should be considering. Okay. Give it orally. 1 to 2 weeks is typically overkill for something like this. However, diabetic patients historically are slow healers, so you might need to leave them on it for 2 weeks. Okay. I do not include clindamycin here. You'll find it in the guidelines, and perhaps this is just my own personal opinion at this point, so take it with a grain of salt substitute. But the incidence of resistance to clindamycin continues to go up, and it's in the neighborhood of 30-some% to staph. Okay, and the resistance can also be inducible. So if you get data back from the lab suggesting that it's resistant to erythromycin, it's going to be resistant to the clindamycin. Okay, and that's the ERM gene coming into play there. That's my first concern about using clindamycin. My second concern is that I just have a hard time considering giving somebody 450 milligrams of clindamycin 3 times a day for 2 weeks. The adverse effects associated with that regimen probably are more risky than beneficial. So this wouldn't necessarily be my go-to, right? You treat one infection while at the same time all you're doing is creating another. All right, the risk of Clostridium difficile infection, I just don't think it's worth it. And it's not nearly as high with either doxycycline or Bactrim. Okay. Moderate infection, again, moderate is in the eyes of the beholder. You have some objective data in front of you to determine whether or not it's moderate or severe. For a moderate infection, if you think you have a good patient that's going to take oral and you have confidence in your oral regimen, you can try oral. I think most people these days are going to be a little bit more aggressive and initiate some IV therapy and then de-escalate to oral upon discharge from the hospital. And the guidelines will say that you're going to treat for about 1 to 3 weeks here. Considering those bottom two again, if you suspect MRSA. And then if it's severe, not surprisingly, we are going to go all out. Broad spectrum antibiotics, debridement. We're going to treat for probably upwards of 4 weeks. Initiate with IV therapy and then de-escalate to oral therapy once things start to improve. Okay. MRSA, Pseudomonas, Enterobacterales, anaerobes. It's everything until it's identified. Okay, until the organism or organisms are identified. If you have a severe infection and it goes pretty deep down, chances are the bone is going to be involved. The bone infection leads to this osteomyelitis. Osteomyelitis often requires a surgical procedure as well. Not only do you have to cut out the infected tissue superficially, subcutaneously, and deeper down, you have to get to that infected bone And depending on how long that bone has been infected, you may have dead bone, which needs to be cut out as well. So this goes back to this concept of source control. We have to control the source. If we can control the source, then the antibiotics are important, but don't really become that important, right? You get rid of the source of the infection, the antibiotics are there to, treat the provider instead of the patient, in my opinion. And the last thing I'll leave you with here, Viva study. For a long time, whether it was diabetic foot infection, a joint infection, prosthetic joint, or bone infections, which we're going to talk about here in a minute, it was IV therapy, IV therapy, IV therapy, 6 to 8 weeks. I mean, think about the impact that has not only on the healthcare system, but the patient and then the family as well. So it's a pretty big burden to try and get somebody to an infusion center every day to get some type of antibiotic to treat a bone infection. But this Aviva study basically looked at individuals who had a bone infection, bless you. What they did is they took a large group of individuals, okay, and cut them in half, not the individuals, the numbers. And half of the group got oral therapy, half the group got IV therapy. Okay? And then they compared the outcomes at the end, recurrences, if you will. And they were almost superimposable, 14% and 13% recurrence in an oral group versus an IV group. So what does that tell you about the need for IV therapy? Oral therapy is just as good. Oral therapy is just as good, as long as you can get your patient to be compliant with it. So we'll talk more about osteomyelitis here in a second. Diabetic foot infection. You guys are all going to take care of diabetic patients. You got to tell your diabetic patients to take their shoes off and look at their feet. If they can't look at them, have somebody else look at them. Okay. A diabetic foot. You know what a big reason why diabetic foot infections come back after they get initially managed? It's the shoe. What do? You come in with one particular pair of shoes, been wearing that pair of shoes, you walk around in that pair of shoes. That pair of shoes that you've been wearing creates the wound in the first place. Get it all cleaned up, and what do? You put that same pair of shoes back on. But there are resources out there to get you a good pair of shoes, get your patient a good pair of shoes that's going to prevent that from happening. Just don't know how pervasive it is in the continuity of care for the patient. All right. Osteomyelitis. We'll get through this pretty quick. Okay. As far as osteomyelitis is concerned, again, I'll just show you a couple anatomical features that predispose to osteomyelitis, and then we'll look at some statistics, and then we'll look at the pathogenesis of osteomyelitis, how these patients present, and then how this infection is typically treated. All right, so when you talk about osteomyelitis, really what you're referring to globally is a bone infection. But when you break that term down, you're talking about bone marrow inflammation. So it's an inflammation of the bone, though. You can leave it at that. There's a variety of different ways to classify osteomyelitis, but I think one of the more common mechanisms to classify it is the Wald-Vogel scheme. And this looks at how the infection occurred, whether it was hematogenous or non-hematogenous, and then the duration. Is it acute or is it chronic? Okay, so a couple different ways to classify that. Mechanism, again, hematogenous. We had a moment of bacteremia that seeded a bone, right? Versus non-hematogenous. The individual that has the diabetic foot ulcer that is infected, that spreads to the bone, that's contiguous spread. And then duration. It can be acute, on the order of a couple days to a couple weeks, or it can be chronic, right, where it can be months to years. And when you see chronic osteomyelitis, you actually see some dead bone on an x-ray that has detached. And then you may see something called a sinus tract, which essentially is a portal from the area of infection in the bone leading out to the surface of the limb. Okay. So sequestra or a sequestrum is essentially a piece of necrotic bone that breaks off. And you look over here at the top right, this area here is meant to represent a detached segment of bone. Okay, that area of infection gets swollen secondary to inflammation and the bacteria. That swelling leads to what we'll say is ischemia. Right? Ischemia, decreased blood flow, prevents vascularization of the bone, decreased blood supply, increased medullary pressure from the inflammation. And then basically the bone just dies secondary to ischemia. And then this sinus tract, again, too, it's the drainage portal. When you see a sinus tract, that's pretty much what we say is pathognomonic or diagnostic for a chronic osteomyelitis. Sinus tract, chronic. No sinus tract, not necessarily chronic. So if you pretend here's the lower leg, bacteria seeded a portion of the bone in the lower leg. And then it starts to replicate, starts to create pressure. It may form something called a subperiosteal abscess. So the periosteum is this covering of the bone layer as it starts to push out. That periosteal abscess gets formed, it's creating pressure on that lining. And then ultimately, secondary to ischemia, the bone dies off, breaks off, and you form this sinus tract, this drainage portal. And that tells you you got something that's been festering for a while. I like this image because if you take a closer look here, you can actually see the shaded area around that segment of bone. So it's probably been infected for a little bit of time, and it has literally detached from the longer segment. Osteomyelitis occurs more often in men than women, about 22 cases per 100,000 person years. This incidence is increasing. Diabetes, not surprisingly, contributes to that. And again, the toes and the feet help increase those numbers. This should come as no surprise. Staph and strep, most common causes of osteomyelitis. And then age. Age is important because it kind of helps you predict where the osteomyelitis is going to be if one is present. In younger children, the long bones fall victim to bone infection. In older individuals, the vertebral column is the most common site of bone infection. So you get vertebral osteomyelitis, which can be very, very scary. There's a couple other areas in the body that also get infected as we age. Young children get infected via hematogenous spread. Adults, typically contiguous spread. When we talk about non-hematogenous osteomyelitis, again, non-hematogenous, this is a wound on the body that seeped into the bone to cause the infection. So an infection elsewhere seeded the bone. You have an abscess, you have a decubitus ulcer, you have a diabetic foot. That can cause a non-hematogenous osteomyelitis. A traumatic event, trauma to a bone, right? Motor vehicle accident can cause osteomyelitis. A penetrating wound, right? Step on a nail, right? It hits the bone. You are directly inoculating bacteria into the bone. Surgical procedure, obviously, okay? Young adults most often have trauma, some form of trauma leading to their osteomyelitis, right? And then older adults have contiguous spread, right, as a cause of their non-hematogenous osteomyelitis. Diabetes, that goes without saying. Diabetes couples well with poor wound healing and peripheral neuropathy and vascular disease. You do not need to have diabetes to have peripheral neuropathy. You do not need to have diabetes to have peripheral vascular disease. Okay. But if you have diabetes, there's a good chance that you do have that. Non-hematogenous infections can be monomicrobial or polymicrobial. Right? Think about where this is coming from. If I have that diabetic foot ulcer that's infected, chances are if it's a deep infection, which it ought to be if it's causing an osteomyelitis, it's going to be polymicrobial. Okay. If it's a superficial diabetic foot infection, it's staph or strep, and we don't get too worried about that causing an osteomyelitis. Okay. In individuals with a non-hematogenous osteo, if it's acute, these symptoms may occur over a couple of days. They'll have a dull pain associated upon movement. Right? That child is just gonna, or that adult's gonna just complain about it. Oh, and then when I walk on it, it starts to hurt. It just starts to hurt, and then when I stay off of it, it's fine. So dull pain upon movement, and then systemic features as well: fever, rigor, leukocytosis. The same thing we've been talking about the last couple of days. In the chronic scenario where that osteomyelitis has been festering for quite some time, pain, swelling, erythema, probably present. Fever may be absent at this point. The body has adjusted, so to say, and they may have that draining sinus. And then as far as labs are concerned, in the acute setting, you would expect to see a leukocytosis because your body is trying to react to the presence of the infection. But then we have these other markers that you're familiar with ESR, erythrocyte sedimentation rate, and then C-reactive protein. Have you guys talked about these two markers in any of the courses? What about rheumatoid arthritis? Have you had RA yet? Did Masler talk about ESR and C-reactive protein at all? What do you know about them? What are they used for? For rheumatoid arthritis. So if somebody has an elevated C-reactive protein or an elevated ESR, that's diagnostic for rheumatoid arthritis. Now, I disagree. Thank you. Because they are non-specific inflammatory markers. So what you actually have here is you have two proteins, C-reactive protein that's synthesized by the liver, and during an infectious process, that C-reactive protein is going to be turned on by a variety of different cytokines, interleukins, TNF alpha, okay? And then the erythrocyte sedimentation rate. So what happens during an inflammatory process is you make more and more fibrinogen. That fibrinogen will grab onto the red blood cells and form something called a rouleau complex, which is just a string of red blood cells. And what that does is it causes the red blood cells to fall faster as compared to individuals who aren't infected or who don't have an inflammatory autoimmune disease, actually. So they're called acute phase reactants is what they're really called. And they are non-specific indicators of RA in particular. They follow these two things, these two lab values in RA, and they also follow it in diabetic foot and osteomyelitis. So as the C-reactive protein gets upwards around 3, 5, 10 milligrams per liter, or as the ESR rate goes upwards to 30, 40, 50, 100 millimeters per hour, right? You're clearing or sinking down a lot of red blood cell at a very fast rate. And that tells you that your body is reacting to the presence of some type of inflammatory condition. Okay. And then in the chronic state, leukocytosis may be absent at this point. The body has equilibrated. And then these inflammatory markers, they may or may not be elevated. So you have physicians out there that will follow ESR and CRP serially because they want to see these go down. They want to see them normalize to suggest that we're getting response to our therapy and resolution of the infection. But if it goes from 7 to 5 and sort of stays there and goes down a little bit, I mean, I don't know how reliable following serial ESR and CRP is. Now on the hematogenous side, so that was non-hematogenous contiguous spread. Hematogenous osteomyelitis. Right? This means that you have a moment of transient bacteremia. You have some type of bacteria that got into the blood for whatever reason. It circulates through the blood and finds an area that's welcoming, so to say. When I say welcoming, what that really means is that you have an area that's been disrupted or damaged, okay? And the bacteria, in particular Staph aureus circulating through the blood finds an area that's been damaged in the past, and as it goes along, it's like, oh, what is this? This is comfortable. I'm gonna grab onto this and kind of just stay here. All right. So these adhesions that Staph aureus makes allow it to stick to a damaged surface. And as it sticks there, it's going to just start to replicate, replicate, replicate. Okay. And this could definitely be inside a bone, inside of the vertebra, the vertebral column, or inside a long bone. The blood supply in the bones is very, very circuitous. It's not like a straight linear flow. So they go in and then they come up. You've got these things called Volkmann canals and Herbersian canals that allow the blood to kind of make its way to the center of the bone. So it's not like this nice, flat, long vessel. It kind of curls around and does this and then comes back out. And likewise, in the vertebral column, the blood flow, especially in an older adult, is described as sort of like a corkscrew shape. So all of these perturbations and nuances in the blood vessels themselves allow for a virulent organism like Staph aureus, which is designed to stick anyhow, to grab onto that foci, that area of damage, start to replicate. The real question is, how did the staph get in the blood in the first place? Okay, so what type of procedure, what type of insult did that patient experience which allowed that transient bacteremia to occur? Well, if you have infective endocarditis, that is essentially the same thing as saying persistent bacteremia. So that can certainly lead to a vertebral osteomyelitis. Intravascular devices, orthopedic hardware. Again, hardware, you're putting a metal or polyacrylamide or plastic foreign body in a joint per se. What better surface to grab onto? People who inject drugs, intravenous drug users, I mean, they're not sterilizing their veins before they inject themselves. And you know how they clean their needles? They go like this. So people lick their needles before they go in. They think it's going to provide some lubrication, but you know what it does? You had the staph and strep in your mouth, now around your needle, which then goes into your vein. Not good. Individuals who get hemodialysis, again, too, those poor folks, they're getting poked and prodded all the time. So that increases the risk of infection. Bacteremia, and then the bacteremia can go on and seed the bone. And then again, sickle cell. Sickle cell is fraught with a lot of risks as well. It doesn't always have to be staph or strep. There are, salmonella is actually pretty common for osteomyelitis in sickle cell patients. Okay. So when it's monomicrobial, staph, and staph. I mean, I'm sorry, if you gave me 5 blood cultures from individuals that had osteomyelitis, I'd bet $100 that all 5 of them are staph. That's how common staph is for osteomyelitis. The best way to diagnose osteomyelitis, a bona fide bacterial infection in the bone, is to get a bone biopsy. So getting the bone, sending that off to the lab and allowing the lab to culture a bacteria and then give you sensitivity data on that is the gold standard. Yeah, and I see how it makes you cringe to even think about that. That is the gold standard. However, there are other mechanisms that allow for diagnosis of osteomyelitis. If you have, remember that x-ray that I showed you a couple slides ago where that bone was detached? If you have an image like that, and then you have a positive blood culture with an organism that is consistent with causing osteo, that's going to be good enough as well to confirm a diagnosis. You should consider osteomyelitis in an individual who has worsening musculoskeletal pain and a poorly healing wound or a skin or soft tissue infection, a recent surgical wound, a bite, some area of trauma, or a diabetic. Felt fine yesterday, didn't do anything, but I got this wound that's been festering on the back of my leg, and now my hip is just killing me. It's like, okay, that warrants some investigation. Bacteremia and fever coupled with musculoskeletal pain ought to put osteomyelitis on your differential, okay? Biopsy. Biopsy, or positive blood cultures with a radiographic finding. If possible, get the bone biopsy regardless, okay? If you have an x-ray that shows a sequestrum, that's dead bone. It's going to have to come out anyhow in order to achieve a cure. And while you're in there, you can take that bone and figure out what's causing the infection. So if you can figure it out and you know exactly what the offending organism is, you can narrow your treatment right off the bat. For non-hematogenous, again, contiguous spread, you need to start asking yourself a variety of different questions. And this is where things really get complicated with regard to prosthetics. But is there any hardware in the patient? You all have friends or individuals that had this horrible sports-related injury or this accident while playing whatever in the backyard. And they broke something such that they actually had to put a plate or screws in to stabilize. I mean, if you have that scenario, and now you have some type of non-hematogenous osteomyelitis, does that hardware need to be there in the first place? Has it been long enough? Can we remove it without disrupting the integrity of the bone? Because all that hardware is going to do is just allow things to fester. If the hardware has to stay put, and that's the site of the infection, and we want to try and do our best at debridement and then give antibiotics. If you look into this area of medicine, infectious disease and osteopathic medicine, they will use an acronym called DARE, and that stands for debridement, antibiotics, and then implant retention. Okay, so individuals where it's going to do more harm than good to pull out whatever was placed in the body, this might be the first approach. Source control requires you to remove the dead necrotic bone and clean out that area, culture, and kill. And again, keep in mind, due to the pathophysiology behind this infection, the blood flow to the bone itself, the long bone or the vertebral column, may be okay, but when you start to try and get blood flow to the site of infection, the bacteria have taken over, and there's a compression effect, a bulk effect that is decreasing blood flow to that site of infection. So giving IV antibiotics, giving oral antibiotics, those antibiotics are going to have a hard time getting to the site of infection in the first place. That's why cleaning out the source alleviating some of that pressure and reestablishing blood flow ends up being important for osteomyelitis. The patient has an infection in the bone, you go in, you remove the dead bone, the devascularized bone, you clean it up really, really well, you give some antibiotics afterwards, they should do okay. However, if you can't get all the dead bone and there is infectious material, unfortunately, left over after the surgical procedure, now we're talking about prolonged antibiotics in order to achieve that medical cure. And it's interesting because what antibiotics do you use? You want to use antibiotics that have a high bioavailability, and you want to have a regimen on hand that's going to allow for adequate bone penetration. Right? You want it to get in there and stay there. One of the more common drugs that is used for osteomyelitis are the fluoroquinolones. They have a lot of data on fluoroquinolones and bone penetration. And what does prolonged mean? On average, about 6 weeks. And 6 weeks because that's what the data suggests the time to revascularize and heal bone is. Once you go in there and cut out a chunk of bone, it's going to be on average about 6 weeks for complete healing. And likewise, I mean, this looks pretty awful if you ask me, seeing some of these bolts that are placed in the bone to hold things together, but it happens. Is it needed? Maybe, maybe not. If it's not needed, take it out. If it needs to stay, clean it up best you can, and then give antibiotics. Again, somewhere on the order of 6 weeks. And then some individuals might actually get chronic suppressive antibiotics after that initial therapy. And so this is pretty similar in terms of hematogenous and non-hematogenous. I'll make special mention here of vertebral osteomyelitis. This is the most common form in your older adults. Again, you get that corkscrew circulation that ends up developing in the vertebral column. So if you have this corkscrew blood flow, it's not that hard then for staph to kind of lodge itself in an area of low flow, so to say. And then when it lodges itself and starts to replicate, here's a nice healthy area of the vertebral column. And you have the disc in the middle. And then over a period of time after seeding the disc or seeding the vertebral column, you get discitis or osteomyelitis. And then ultimately, you can see a collapse or failure in the bone secondary to that infectious process. Okay, so that's pretty scary because your vertebral column is surrounding a lot of important nerves, and plesias can occur. So you can have some serious deficit in motor ability as the vertebral column starts to compress. So cord compression is a big concern. And they might have to go in here and decompress that area and then put some hardware in there to stabilize the vertebral column and allow for it to fuse over time. So what antibiotics do you use to treat osteomyelitis? What do you want to use for osteomyelitis? What questions do you think you need to ask up front when you have somebody present with what appears to be a bone infection? What's question number one? Allergic to any medicine. And that's just the reality of it. Don't get tricked on the Naplex because they will do that. You have any allergies? No known allergies. Perfect. Who is it? Is it an adult or a child? If it's an adult, probably going to be vertebral or sternal, and maybe even iliac crest, some common sites of osteomyelitis in an adult. If it's a child, it's going to probably be a long bone. Okay. How long has it been? How long has your symptoms have been occurring? A couple days, we got an acute infection. All right. If you've got this long-standing infection, that's going to be evident by the presence then of a sinus tract. Okay. How are the symptoms? Are they in pain? How do they look? How ill are they? In other words, is it emergent? Do you need to start antibiotics right now? Or are they stable? Okay. What's the benefit of having a stabilized patient who's presenting with what might be an osteomyelitis? What does it allow for? You can go in, get the appropriate blood cultures. That's going to happen right off the bat. But then you can also go in and try and get that bone biopsy. If you can get that bone biopsy, then you can give definitive treatment as your initial treatment. You can save the aggravation of using broad spectrum antibiotics. You can reduce toxicities. You can reduce adverse effects if you can wait. And that's often the case for a lot of people. Most of the time, this isn't emergent. Okay. If it is emergent, suggesting that they not only have an osteomyelitis, but they probably have a massive abscess or a cellulitis or a vascular infection, and they're borderline septic or they're in sepsis, that changes things. So you have to let the absence or presence of Sears criteria really guide your decision on when to start antibiotics. If I come to you and I'm complaining about this, my leg hurting, and I've got a small abscess here, okay, well, let's drain that abscess. Let's take care of that source. Let's do an X-ray. Oh, you've got, a little bit of a detached piece of bone here suggesting an osteomyelitis, but you're otherwise hemodynamically stable. We're gonna hold off until we get the results back to start antibiotics. Perfect. Opposite to that, if it's me and I have the bigger abscess, and I've got this area of detached bone, and I'm sick, hypotensive, respiratory rate's up, heart rate's up, I have a profound leukocytosis, yeah, that's different. Get the blood cultures. To heck with the bone biopsy for now. We need to start them on antibiotics, IV antibiotics. Okay, just to give you a little bit of a flavor about how aggressive you should or shouldn't be. Staph and strep. And then the rest of these charts, I mean, you guys gotten to the point where you can just fill this in. You don't need me to tell you, what's what, but it's on the next slide if you're interested. And I want to emphasize here, this is definitive therapy, okay? This is what the expectation is. Empirically, MAPOM. Definitively, smart bomb, okay? So you blast the area if needed with broad spectrum antibiotics up front, but when you know it's MSSA, you know you can use this, or this, okay? If you know it's MRSA, then you DC that, and you put them on Vanco or Dapto. All right. There isn't always agreement on length of therapy. 6 to 8 weeks, though, in general, is what's recommended from the various experts for MRSA. And then methicillin-resistant staph epidermidis. Most staph epidermidis, coag-negative staph, is going to be methicillin-resistant. So again, you're probably going to end up using Vanco in these scenarios as well. However, if it does prove to be methicillin susceptible, you revert back to the anti-staphylococcal penicillins or a first generation cephalosporin. And then you can look through the rest of these. The rest of this just makes sense. I mean, just think about it. You think about what might be causing the infection, and then you think about how to address that. Okay. We'll say here, I say staph and strep most often, and that's true. But if you have that individual that has a urinary tract infection, your patient came in and she has a pyelonephritis, and she's sick from that, and she's kind of hunched over like this because she's a little bit older and it's got some vertebral damage. I mean, if she has an osteo and she has a urinary tract source, there's a good chance that that's going to be a gram-negative organism causing that. Okay. And then strep, what do we use for strep? Penicillin. All right. The whole concept of biofilms is a whole nother story. And we'll pick this up next time we meet, or I'll give you something to read about biofilms. But no, we did it. Yay. Yay for us. Congratulations. What questions do you have? Concerns? You guys really seem to be out of it today, more so than usual. What's going on? Exam on Wednesday, has that got you? Got endocrine on the mind? What did Rihanna say? Right? Black and blue from endocrine? No. Bad joke. Okay. I like Rihanna. I don't know if I told you that.